Hello, welcome to Sonography Radiology Training Channel. This series of videos is about abnormal fetal growth. This is the 6th video in this video series with title of Fetal Macrosomia Part 2. In video part 1, these items were explained. In video part 2, the major syndromes associated with fetal overgrowth will be explained. If constitutional factors, maternal diabetes and/or maternal obesity, excessive gestational weight gain have been excluded or seem unlikely, then the possibility of one of the rare syndromes associated with accelerated fetal growth should be considered, particularly in the presence of one or more fetal structural anomalies. A large number of genetic conditions has been associated with overgrowth. Therefore, consultation with a geneticist can be useful to help with differential diagnosis, prenatal diagnostic evaluation, for example, selection and interpretation of molecular testing, and patient counseling. Some of the major syndromes associated with fetal overgrowth include Bannayan-Riley-Ruvalcaba Syndrome, Proteus Syndrome, Klippel-Trenaunay Syndrome, Megalencephaly polymicrogyria, polydactyly Hydrocephalus Syndrome, Pallister-Killian, Beckwith-Wiedemann Syndrome, Sotos Syndrome, Perlman Syndrome, Simpson-Golabi-Behmel Syndrome, Costello Syndrome, Weaver Syndrome, and Macrocephaly-cutis marmorata, telangiectasia, congenita syndrome. The first one is Bannayan-Riley-Ruvalcaba Syndrome. PTEN is a tumor suppressor gene. The PTEN hamartoma tumor syndrome includes Cowden syndrome, Bannayan-Riley-Ruvalcaba syndrome, PTN-related Proteus syndrome, and PTN-related Proteus-like syndrome. Proteus-like syndrome is undefined but refers to individuals with significant clinical features of Proteus syndrome who do not meet the diagnostic criteria for Proteus syndrome. This syndrome is the most severe disorder in the PTEN-related overgrowth spectrum. It's characterized by macrocephaly, lipomatosis, intestinal hematomatous polyposis, and pigmented penile macules. Developmental delay is common also. Recurrence risk is 50% with an affected parent. Diagnosis is based on macrocephaly, intestinal hematomatous polyposis, lipomas, and pigmented macules of the glans penis. Official diagnostic criteria have not been set for this syndrome. Other features can include myopathy of the proximal muscles, joint hyperextensibility, scoliosis, and pectus excavatum. Prenatal diagnosis is very rare. Proteus syndrome. Proteus syndrome is very rare and characterized by progressive segmental overgrowth of body tissues, most commonly the skeleton, skin, adipose tissue, and CNS. Most overgrowth occurs postnatally. Proteus syndrome is distinct from other overgrowth syndromes because most overgrowth is postnatal and is distorting and progressive. A few individuals, less than 5%, may have the prenatal finding of hemimegalencephaly or lymphangiomas. Distortion of the skeletal system is characteristic, for example, leg length discrepancy of up to 20 cm and scoliosis greater than 90 degrees. Cerebriform connective tissue nevi are present in most individuals and are virtually pathognomonic for this syndrome. Other features include adipose dysregulation, vascular malformation, bullous pulmonary degeneration, and overgrowth of other organs like spleen, liver, thymus, and gut. Klippel-Trenaunay Syndrome. It's characterized by congenital vascular malformations, capillary venous or lymphatic, and altered growths of bone and soft tissue, most commonly as hypertrophy or less common as hypertrophy of a small or large body part. The other malformations are generally on the extremities and adjacent regions of the trunk. The vascular malformations are often located in the same body side as the growth disturbance. The diagnosis is based on the clinical features of vascular malformations and distorted growth of bony and soft tissues. Other common features include limb anomalies, polydactyly or syndactyly, skeletal malformations, scoliosis, hip dislocation or club feet, and autonomic dysfunction. Prenatally asymmetric limb growths may be detected. This is an example of prenatal diagnosis of Klippel-Trénaunay Syndrome. We can see the leg of the fetus has 20 weeks gestation with marked edema. This is an example of prenatal diagnosis of Klippel-Trenaunay Syndrome. We can see here a cystic structure predominantly along the left half of the chest and also a mixed structure in the right lung. Color Doppler image shows cystic and solid structure in the lower abdomen without detectable color follow signals. 3D image shows enlarged left leg, and this image shows abortive phenotype. Note the purple stains, predominantly affection of the left side of the thorax and swollen left lower limb. Megalencephaly polymicrogyria polydactyly Hydrocephalus syndrome. PIK3CA-related overgrowth spectrum encompasses a range of clinical findings in which the core of features are congenital or early childhood onset of segmental or focal overgrowth with or without cellular dysplasia. This syndrome is characterized by congenital megalencephaly, bilateral perisylvian polymicrogyria, and post-axial polydactyly. It's associated with an increased risk of hydrocephalus. The diagnosis is based on characteristic brain findings, including megalencephaly, ventriculomegaly or hydrocephalus, and cortical brain abnormalities, especially perisylvian polymicrogyria. Post-axial polydactyly is present in a subset of affected individuals. Many features overlap with megalencephaly capillary malformation syndrome, but this syndrome lacks vascular malformations, focal asymmetric overgrowth, and syndactyly. Additionally, overgrowth in this syndrome tends to be symmetric, in contrast to asymmetric overgrowth can be seen in M-CMTC syndrome. Pallister-Killian syndrome. Another name for this syndrome is tetrasomia 12p. Human autosomal tetrasomies are rare. Among them, the tetrasomia 12p is undoubtedly the most common. The most common prenatal finding includes congenital diaphragmatic hernia, short limbs, CNS anomalies and ventriculomegaly, craniofacial dysmorphism, increased nuchal translucency, fetal hydrops, and polyhydramnios. This is an example of prenatal diagnosis of Pallister-Killian syndrome. This 2D ultrasound image of fetal profile demonstrating flat fetal face with flat nose and increased prenasal thickness. 3D ultrasound image show abnormal fetal profile, respectively flat face with high forehead and flat nose. Another 3D image shows fetal face with flat wide nose and introverted nostrils and outer eye corners pointing downwards. Another example of perinatal diagnosis, we can see increased nuchal fold thickness, mild hydronephrosis of both kidneys, a small omphalocele here with partial herniation of the liver and displacement of the fetal gallbladder. Pulse Doppler of the tricuspid valve shows tricuspid regurgitation. The diagnosis can be confirmed by amniocentesis or chorionic villus sampling. Beckwith-Wiedemann syndrome. Prenatal findings include macrosomia, macroglossia, omphalocele, polyhydramnios, long umbilical cord, and enlarged placenta. Many of these features are not present until the late second trimester. This is an example of prenatal diagnosis with obvious macroglossia, and also in fetal abdomen we can see obvious hepatomegaly. Prenatal anomalies may be present and include medullary dysplasia, duplicated collecting system, cystic changes, and nephromegaly. This is another example of prenatal diagnosis of Beckwith-Wiedemann syndrome. In this fetus, we can see nephromegaly and also an enlarged pancreas. Embryonic tumors may be present early in life, including Wilms tumor and hepatoblastoma, as well as neuroblastoma, adrenocortical carcinoma, and rhabdomyosarcoma. Hemihyperplasia can often be seen at birth, but may become less pronounced as a child grows. Sotos syndrome. Sotos syndrome should be considered with overgrowth more than 2 standard deviations with advanced bone age and characteristic facial features. Facial features include malar flashing, frontal boosing, spurs higher in the frontotemporal region, down-slanting palpebral features, long narrow face or triangular shape, and prominent jaw. These features are most apparent between age 1 and 6 years old. Other associated features include CNS anomalies like ventriculomegaly and midline clefts, congenital heart defects, renal anomalies, scoliosis, seizures, and behavioral problems. Maternal preeclampsia occurs in approximately 15% of pregnancies of children with Sotos syndrome. Because many of its symptoms appear after birth, so prenatal diagnosis is very rare. Prenatal diagnosis of fetal overgrowth, polyhydramnios, macrocephaly, and renal and central nervous system abnormalities should consider a detailed examination of parents for the phenotypic features of Sotos syndrome and mutational and microdeletion analysis of NSD1 gene in the fetus. Perlman syndrome. Perlman syndrome is characterized by prenatal overgrowth. Dysmorphic facial features include a small unturned nose, small mouth, deep-set eyes, low-set ears, crease over the nasal bridge, visceromegaly, and predisposition to Wilms tumor. Prenatally, polyhydramnios, fetal macrosomia, nephromegaly, and fetal ascites are common. Neonatal findings include macrosomia, nephromegaly, hepatomegaly, hypotonia, abdominal distension, cryptorchidism, and dysmorphic facial features. Nephroblastoma and Wilms tumor are common. Recurrence risk is 25% if both parents are mutation carriers. Simpson-Golabi-Behmel syndrome. It's characterized by prenatal and postnatal overgrowth, a characteristic facial appearance including macrocephaly, coarse facial features, macrostomia. Macrostomia is a primary cleft defined as enlargement of the mouth at the oral commissure. Macroglossia, palate anomalies, and intellectual disability. Affected individuals are at high risk for the development of embryonal tumors. About 10% of individuals, including Wilms tumor, hepatoblastoma, adrenal neuroblastoma, gonadoblastoma, and hepatocellular carcinoma. Inheritance is X-linked. With a maternal mutation carrier, there is a 50% chance of transmitting the mutation to each child. Males who inherit the mutation will be affected, and females will be carriers, although they can exhibit clinical features owing to skewed X inactivation. The diagnosis is based on clinical features and a family history suggestive of X-linked inheritance along with molecular genetic testing. The diagnosis should be considered in the setting of macrosomia, characteristic facial features, and associated congenital anomalies. These anomalies can include CNS anomalies, supernumerary nipples, umbilical hernia, diaphragmatic hernia, congenital heart defects, genitourinary defects, GI anomalies, skeletal anomalies, and hand anomalies including large hand and post-axial polydactyly. This is an example of prenatal diagnosis of Simpson-Golabi-Behmel syndrome. This ultrasound image shows increased nuchal translucency at 13 weeks of gestation. This image of fetal abdomen shows a simple cystic structure in the abdomen, most probably a gastrointestinal duplication cyst, hyperechogenic kidneys, and this image shows malposition of the fetal heart in the chest at 13 weeks. The position of the fetal heart is in the middle of the thorax. The images of the same fetus at 22 weeks show streaking profile and brain structure in the fetus, suspicion of congenital diaphragmatic hernia, and also increased subcutaneous fat tissue. Costello syndrome. The pregnancy of a fetus with Costello syndrome is often complicated by polyhydramnios, and prenatal ultrasound may show shortened long bones, ulnar deviation of the wrists, macrocephaly, and/or ventriculomegaly. Fetal tachyarrhythmia is noted in 18%. Preterm delivery occurs in 24 to 41%, and about 50% of infants are large for gestational age. This is an example of prenatal diagnosis of Costello syndrome. This image shows a 25 weeks fetus with Costello syndrome showing high forehead, broad nasal tip, thick lips, and low-set ears. This image shows highly echogenic thickened subcutaneous tissue of the thorax representing cardiac myopathy. In fetal heart, we can see a septum in the left atrium, which was confirmed postnatally as core triatriatum. Doppler assessment identified fused E and A wave of filling patterns in right and left ventricles, and Doppler ultrasound of ductus venosus shows fused S and D waves in ductus venosus. Another findings in Costello syndrome include cutis laxa, that is extra stick loosening of the neck, palms, and soles of the feet, and also developmental delay. Multiple papillomas in the face around the anal region, cardiac abnormalities, and short stature. The characteristic facial profile includes low-set ears, thick lips, macrocephaly, depressed nasal bridge, and widening of nostrils. Weaver syndrome. Weaver syndrome is characterized by tall stature, characteristic facial features, and other clinical features, including advanced bone age, poor coordination, umbilical hernia, abnormal tone, hoarse cry, camptodactyly of fingers or toes, which is bent finger. The synonym for this syndrome is EZH2-related overgrowth. Recurrence risk about 50% with an affected parent. On a prenatal ultrasound, bones are longer than average, and also fetal macrosomia. The diagnosis is based on tall stature, means the height more than 2 standard deviation, characteristic facial appearance including retrognathia, large flashy ears, stack-on appearance of chin with central dimple, hyperchlorism, round face and cheeks, broad forehead, and almond-shaped palpebral fissures, and other associated anomalies. And finally, Macrocephaly-cutis marmorata telangiectasia congenita syndrome. It's a rare congenital syndrome of unknown etiology characterized by macrocephaly and vascular lesions that have been described as either cutis marmorata or cutis marmorata telangiectasia congenita. Associated anomalies include body asymmetry, which is most frequently anomaly. This includes asymmetry of the limbs, trunk, and face as a result of either hypertrophy or hypotrophy. Also may be seen neurological defects and ophthalmological complications, which is the third most frequent anomaly, and half of which were congenital glaucoma. Another associated anomalies include cardiovascular defects, Mongolian spots, dysmorphic features, genitourinary defects, and endocrinological defects. In summary, here we can review the distinguishing findings of each syndrome. In Bannayan-Riley-Ruvalcaba Syndrome, we can find macrocephaly prenatally and postnatally. Distinguishing findings are intestinal hematomatous polyposis and pigmented macules of the glans penis. Less than 5% of cases of Proteus syndrome may diagnose prenatally with hemimegalencephaly and lymphangiomas, but we can find skeletal system distortion, especially postnatally, and cerebriform connective tissue nevi, which are pathognomonic for this syndrome. Klippel-Trenaunay Syndrome, asymmetric limb growth, vascular malformations, limb anomalies, polydactyly or syndactyly, and skeletal malformations. In Megalencephaly, polymicrogyria, polydactyly, Hydrocephalus syndrome, we can find macrocephaly, ventriculomegaly, post-axial polydactyly, symmetric overgrowth, and especially in postnatally MRI, we can find perisylvian polymicrogyria. Pallister-Killian syndrome, the distinguishing findings are short limbs, flat fetal face, and flat nose. In Beckwith-Wiedemann, macroglossia, organomegaly, and hemihyperplasia. In Sotos syndrome, macrocephaly, renal and CNS abnormalities, and facial features, especially triangular shape of the face. In Perlman syndrome, we can find fetal ascites and crease over nasal bridge. Simpson-Golabi-Behmel syndrome shows X-linked inheritance, large hands with post-axial polydactyly, macrostomia, and supernumerary nipples. And Costello syndrome, the most important finding is short long bones, ulnar deviation of the wrists, after birth, cutis laxa, and multiple papillomata. Weaver syndrome, we can find long bones, camptodactyly, tall stature, almond-shaped palpebral features. And the last one, Macrocephaly-cutis marmorata, telangiectasia congenita syndrome, we can find prenatally congenital glaucoma, and after birth, cutis marmorata, and body asymmetry. Now, I suggest two others of my videos that are close to this video in terms of matter. And thank you for your attention.